So now we're talking about mobility, immobility, and sleep rest. And mobility is the ability, obviously, to move about freely, um, and immobility is not. Um, immobility doesn't necessarily mean that there's no movement, but it's limited somehow. Bed rest uh, can imply it implies immobility, um, but it can also be an intervention that I choose to use. Body mechanics refers to how we use our body to lift and to do tasks to prevent injury. When assessing mobility, you're going to assess range of motion, both passive and active range of motion. So you're putting the body through the flexion and extension appropriate to that joint, and you're grading it or assigning it a percentage based on how well the patient can move. Just going to ignore planes of the body. Planes of the body are useful for documentation of a location of something, um, but we really don't need it right now. I'm sorry I have the hiccups, so if it sounds like I'm talking funny, that's why. Gait is simply how a person walks. Activity tolerance is um, how much activity can a person do before they become too tired, either short of breath or weak, that it affects them to the point where they are no longer able to do something. So how much activity can they do is your activity tolerance. Body alignment is just what it says. If you could draw a line, um, put a string from head to toe, is everything in alignment? The ears should be aligned with the shoulders. It should be aligned with the hips and the knees and the heels or ankles, more or less. Any alteration in that would be poor body alignment or altered body alignment. If you have a patient who is immobile, can't stand or can't sit, so that you can assess body alignment, you want to assess them lying on their side in bed, because that's going to give you the best picture of body alignment, because you're going to look at the person from a side view if they're standing. There are quite a few terms that you'll want to look at related to mobility as well. Immobility, like I said, doesn't mean total lack of movement. It can mean um, I broke my ankle, and so I'm less mobile than I used to be. Immobility or problems with mobility can be the nurse or the patient. It can be related to things we were born with, arthritis, uh, multiple sclerosis, muscular dystrophy, um, spinal cord injury, COPD, heart failure. So all types of disease processes can have an effect on mobility. In turn, mobility or the level of mobility or the lack of mobility will have an impact on all of these problems as well, because immobility affects every body system, um, from mental status to cardiac, respiratory, bowel, bladder, musculoskeletal, everything. So that's what I just said. Sorry about that. Got ahead of myself. So immobility affects the metabolic system. It changes our metabolism, decreasing our metabolism. So that means we kind of have to decrease our calories. However, we have to maintain adequate nutrients, so that can be a challenge. Respiratory, I'm sure that you can figure out that being immobile for long periods of time allows um, fluids to accumulate in the lungs, um, and lying flat prevents good expansion of the lungs. So we're more likely to have develop pneumonia, atelectasis, um, compromised respiratory system, which is going to lead to poor oxygenation. Um, once we develop poor oxygenation, that's going to affect all of our other systems as well. Cardiovascularly, um, cardiac output falls because not as much blood is returning to the heart. So why is not as much blood returning to the heart? Because there's no muscle activity to force it back up the veins. One of the things that keeps blood returning to the heart is the contraction of the muscles in our legs. For lying down, that doesn't occur. And so fluid pools in the lower extremities. It may be forced out into the tissues, which means now we have edema. It's not circulating as adequately, so a greater risk for clots occurs, and a clot can move and travel to the lungs or the brain, causing a pulmonary embolism or a stroke. But when that cardiac output falls, then we're going to see less oxygenated blood going to the brain, less oxygenated blood going to the intestines, less oxygenated blood going to the kidneys, to the skin. So it's going to impact everything by impacting cardiac output. Musculoskeletal system, when we don't use our muscles, they weaken, they begin to break down. So we're going to lose tone, we're going to lose strength. Joints that aren't used, the ligaments around them begin to stiffen and shorten, and we end up with contractures, which then is going to limit our mobility when we get well. Elimination, without adequate circulation, peristalsis decreases, so we increase risk of constipation and increased risk of retention, not only in the bladder, but in the kidneys, if the patient is never upright or is rarely upright. Integument is skin. So what happens with the skin? It's going to break down because of the pressure and the poor circulation because of cardiac output. So greater risk of skin impairments. Psychosocial, often there's isolation because the patient can't get up and do what they normally would do, which is going to lead to depression. Lack of oxygenated blood is going to affect mood and mental function. And depending on the age and developmental stage of the person, it can delay development, especially in children. Babies born with hip dysplasia who have to be in hip spica casts are obviously going to learn to walk later than other children born at the same time. So we have to anticipate the developmental effects of immobility. Um, when considering our goals, we may collaborate with other people on methods to help the patient increase their activity. Um, a lot's going to depend on what is the cause of the immobility. Is it a spinal cord injury at the level of T2? Well, we can't expect a lot of increase in activity by the patient by the patient. So we have to involve other people to do passive range of motion and to maintain some circulation and mobility of those joints. One of the things that we really want to focus on is prevent the effects of immobility. So providing that range of motion, repositioning every 2 hours or more often. And when we're repositioning, we really want to pay attention to the method that we're using so that we're not causing more damage to the skin or joints by the techniques that we're using. So repositioning the patient is going to have a multitude of positive effects. You already know that it helps to mobilize the fluid in the lungs, and you can figure out that it relieves pressure, so we're less likely to get pressure ulcers. By doing passive range of motion, it can help prevent clot formation because we're forcing those muscles, by flexing and extending the foot. It helps to contract and extend the muscles in the calf, encourages blood flow. And of course, we want to, whenever we're doing range of motion or positioning, talk to the patient so that some of those psychosocial needs are met as well. And once again, I got a little bit ahead of myself. Positioning is probably one of the most important things that you can do. Having the head of the bed elevated helps decrease cardiac workload. The cardiac output falls, but the heart is actually working harder to circulate that blood around because there's a lot of resistance now that the blood is stagnant especially the lower extremities. We know already that it mobilizes pulmonary secretions. It allows gravity to do its job and empty the renal pelvis. So positioning is very important. Pressure ulcers. Of course, the best thing to do is to prevent a pressure ulcer. But if we can't do that and a pressure ulcer starts, we want to stop it in its early stages. The cause of pressure ulcers is tissue ischemia, meaning there's periods of time when blood flow to that tissue has been interrupted. So you're always looking for red areas. You're looking for what you want to see is a red area that blanches and then returns red. that tells us that there's still adequate blood flow and we don't have damage that's going to continue. If it blanches when you press on it, meaning it turns white when you apply pressure, and doesn't return to the red color, then we have a compromised area. And we want to make sure that the patient stays off of that area until blood flow increases. So you want to be able to visually inspect and determine that there's a change in the skin, whether it's just red, it's non-blanchable erythema, whether there's a blister, whether there's an actual opening. So once we have a blister, we have a stage 1 pressure ulcer, and it's going to require some type of treatment. You also have to look at the skin around the ulcer. Sometimes pressure ulcers are really tricky, and they will tunnel underneath what appears to be healthy skin. So sometimes it's larger than you think it is. It's important to measure an ulcer at least once every 24 hours, if not every shift, in order to determine progression or worsening or healing. And then you want to be able to stage the pressure ulcer 1 through 4 or unstageable. So 1 is the easiest to treat. 2, you can see that it goes into the deep layer of the skin and not just the surface. 3, it begins to go into the muscle. And 4, it goes through the muscle and you may see bone. Now, an ulcer is unstageable if it is covered in eschar, which is the black, leathery covering that, depending on who's caring for it, may or may not be removed. Some people want to remove it so they can see how bad the ulcer is, and some people want to leave it because it provides protection. Sometimes when you're measuring an ulcer, you have to measure the depth, and so you might use a sterile Q-tip to put down into the wound and then mark the edge and measure that, or some way that you can measure that appropriately. Okay, now obviously we're talking about sleep, because Snoopy's sleeping. The main thing I want you to know about sleep is that it's cyclical. Everyone has a sleep-wake cycle that influences or is influenced by their physiology and their behavior. Most people have a diurnal sleep cycle, meaning we're awake when it's light and we're asleep when it's dark, versus some animals that have nocturnal. Sleep is the actual loss of consciousness versus rest, which is just closing your eyes and being still. Maybe not even closing your eyes, just being still. Circadian rhythm refers to the 24-hour clock, kind of. Whether you're a morning person or a night person, whether an early riser, you stay up late and get up early, stay up late, get up late, go to bed early, get up late, that sort of thing. So everybody's a little bit different. Physical illness obviously is going to affect someone's sleep, medications that either cause sleep but don't allow a person to sleep well or induce sleeplessness, or insomnia. Lifestyle, again, not having a bedtime ritual sometimes can cause sleeplessness. So, the person who tries to come off of a 12-hour ER shift and fall into bed probably isn't going to go to sleep right away. When assessing a patient, you want to ask about usual sleep patterns. Someone who works rotating shifts is going to have more trouble. What do they usually do? And we kind of covered this when we covered the database. They get in bed at 9, but they read for an hour. What is their usual pattern of sleeping? L-tryptophan. You probably all have heard about that. Have a cup of warm milk before bed will help you sleep. The reason why we all feel sleepy after Thanksgiving meal, not just because we ate a lot, but because most of us ate a lot of turkey and it has L-tryptophan. Napping during the day can, of course, impair the ability to sleep at night. So we obviously want to assess their sleep. What kind of sleep are they getting? But if they are complaining of sleep problems, then we want to know what kind of symptoms are they having. And some of the symptoms that might be experienced are anxiety, restlessness, irritability. We've all seen someone that is irritable because they're tired. Impaired judgment, leading to mental confusion, decreased appetite. Sometimes people will have an increased appetite because they're eating to try to stay awake. So instead of weight loss, they may have a weight gain. Insomnia is the inability to go to sleep or stay asleep. Sleep apnea is an apneic episode, meaning the person stops breathing for greater than 20 seconds while sleeping. Narcolepsy is an uncontrollable urge to fall asleep in inappropriate places. And then sleep deprivation is going long periods of time without sleeping. So I think that ends sleep, rest, and mobility-immobility. So I hope it's helpful, and I will see you later.